Hi, Monty Pal here on behalf of GU Oncology Now. Today we're going to be talking about updates in kidney cancer with three of my dear friends. We're going to start with a quick round of introductions, beginning with you, Cristina.
Hi, I'm Cristina Suárez. I'm a medical oncologist at Vall Hospital in Barcelona, Spain.
Dan.
Hi folks, Dan George from Duke. I'm a GU medical oncologist and happy to be part of the panel.
Awesome. Brad.
Yeah, and I'm Brad McGregor, also a GU medical oncologist from Dana-Farber in Boston.
Awesome. All different parts of the world here. Monty Pal from Los Angeles, California, and we're going to dive right in. The debate that I think is, so challenging to really, opine on is second-line therapy, right? We don't really have a lot of ideal sort of second-line trials to address what we should be using after TKI-IO or IO-IO, frankly. But with that in mind, when we see these patients in clinic, I get several, probably every month that are referred in, who have gotten multiple lines of immunotherapy. Frontline immunotherapy, second-line immunotherapy, third-line immunotherapy. I've seen it out to 5 or 6 lines of treatment, right? With a huge cost burden, presumably some toxicity burden. Brad, what do you think about that? Is it legitimate to continue IO into multiple lines of treatment?
I think we don't know. I mean, truly, I don't think we have data to justify that at this point in time. I can tell you my personal preference is I tend to stop the IO because I worry that I may compromise my dose intensity of the TKI by giving it with an IO. Are we going to have LFT issues? Or there's just going to be some complications. So I think the ongoing trials are going to answer those questions, right? There's ongoing completed trials looking at cabozantinib with or without atezolizumab after progression IO. There's the ongoing TiNivo-2 trial looking at tivozanib with or without nivolumab. And I think that's going to give us some actual data to help guide this discussion. We have we have some great phase 2 data for Pembro that shows this impressive response rate patients who had prior immunotherapy, but is that driven by the lenvatinib, and to what part does the Pembro come into play? So I think this really is something where we need data. I think these trials are going to be critical because we may be doing a harm by continuing with something because we're having to give a lower dose of that TKI than they maybe could tolerate without the IO, and that may hurt them long term.
It's a great point, Brad, because I think sometimes these patients are on treatment so long in the frontline setting, we almost forget the side effects, right? The fatigue is almost something they've sort of come accustomed to or whatnot, and so they live with this, but it's deconditioning. We're not measuring their muscle mass or their functional capacity, but it's affected by these therapies chronically over time. And so, to your point, we may be doing some disservice unless the clinical trials show us that there's a real benefit. And I think that's really what we need. It was interesting to me when you look at NCCN recently, and I don't know if people have looked at that, but they've changed the guidelines regarding refractory disease. A lot of our older trials that were based on, prior frontline therapy of TKI alone are no longer considered level 1 evidence because the frontline therapies have changed.
Yeah.
And some people are a little bit frustrated with that, because it's a guideline, it's not really telling us what to do. But the truth is, if the data doesn't really tell you what to do, then we shouldn't be pretending it does. And I think it creates the unmet need that these newer generation trials will fill. So it's a little bit of a transition time that we're in right now. And I think we're doing the best we can with the data that we have, level 2 evidence. But I think these next generation of kind of refractory trials are really going to help shed light on exactly how we should be managing. And TKI alone in this setting or Len-Ev or these types of combinations, I think are reasonable things to do. And if we don't see a benefit to continued IO, it may be something we study, in the third line setting, having a break and then coming back to that.
That's a very good point.
That's interesting.
I was going to say that.
I wouldn't say that kills future IO therapy forever. I think it would just say
I fully
we
agree
don't
with that.
continue it all the way through.